Sir.
Good evening, all, and welcome to eyesight meeting by Bayer. So we will discuss on the PCV, DME as well as the wet AMD as well. So firstly, I will like to welcome Dr. Harsha Jawarkar, and she is the video surgeon in the Vadodara, and she is also assistant professor at the SVKS Medical College and Dheeraj Hospital, and is also associated with the retina surgeon at the Sardar Hospital, Nizampura. She is specialized in the complex retinal surgeries, advanced laser procedures, and the evidence-based patient care. With the strong focus on the achieving optimal visual outcomes, Dr. Harsha has completed her fellowship in the VR from Nishita Retina Care, Vadodara, and her DNB ophthalmologist in the Rajan Eye Care. So she is also previously associated with the CFS, Vadodara, and the Vasan Eye Care, Kolhapur. So today she will presenting on the evaluating the need for the change, evidence and insights on the anti-VEGF therapies. So ma'am, you can start now.
Yeah, I'm sharing my PPT. Is it visible now, the slideshow?
Yes, ma'am. But it's not in the presentation mode. Now it's visible in the presentation mode. Yes.
Now it is present. Is it?
Yes.
It is in presentation mode, right?
Yes.
One second. So let's discuss this topic of evaluating the need for change, evidence, and insights on anti-VEGF therapies. Thank you, Bayer, for giving me this opportunity. Use of these slides are permitted only for the purpose of scientific and educational presentations. Current management in neovascular AMD or wet AMD are this is the current anti-VEGF treatment choice: bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. Although there is no cure, only timely treatment can help achieve the wet AMD treatment goals of drying the affected eyes by inhibiting the new blood vessels that leak the blood and fluid and improving or maintaining the visual acuity over longer periods. In real world settings, significant gaps and challenges pose barriers to achieving these goals. The challenges in wet AMD management using anti-VEGF are there are significant inter-individual differences in response to an anti-VEGF agent, and the availability of multiple anti-VEGF agents with different molecular configurations also we have to face the challenges because of this. The response to anti-VEGF therapy have been found to be dependent on a variety of factors, like it can be because of patient's age, lesion characteristics, lesion duration, baseline visual acuity, and presence of genotype risk alleles. And there is no currently consensus as to how to classify optimal response or lack of it with these therapies. Primary response is 1 month following the last loading dose. And secondary response is any time after the fourth visit, Q4. The secondary response do not mirror and cannot be predicted from that in the primary phase. There is a ceiling effect that can negate the currently used functional metrics such as more than 5 letters improvement when the baseline visual acuity is good. And important to use a combination parameter to determine the response of anti-VEGF. How to determine the improvement? It is always seen in change in visual function, which is assessed by visual acuity measurement at the baseline and all follow-up visits. And the second parameter is to check the macular morphology, which is assessed by OCT. ICG is usually reserved for some cases like IPCV, polypoidal choroidopathy, or retinal angiomatous proliferance. The response can be categorized as good, partial, poor, or non-response. So, morphological response and functional response. A good morphological response is there is absence of subretinal fluid, intraretinal fluid, introduction and reduction of central retinal thickness to more than 75% of baseline values, which also will correspond with functional improvement in visual acuity more than 5 letters from the baseline value, and it will pay more attention to morphological features if visual acuity is good, especially more than 70%. And partial is reduction of central retinal thickness of between 25 to 75% with reduction of fluid. Poor is between 0 to less than 25% with reduction in thickness and but with persistence of fluid, and change in visual acuity is not much, and totally no response is unchanging of central retinal thickness, and in fact there is more visual acuity deterioration even after taking third injection. If we switch to newer anti-VEGF agents, is it a hope, or it will give a hope, or it will be just a hype? So let's discuss that. So these are the studies done in this, the real world study analysis. After 3 faricimab injections, the Mukai et al. Study showed baseline visual acuity was 65. In treatment naive patients, it was a statistically significant gain in visual acuity, but the sample size was very less, 13. So it was not a very good relevant study. In Truckee study, the baseline acuity was 57.2. When we switched those patients from aflibercept to faricimab, the visual acuity gain was not very statistically significant. As you can see, p-value is only 0.142. But treatment naive patients gave a good visual acuity gain, but the sample size again was very less. So this is also not relevant study. If we do a study of after 4 faricimab injections, Moorfield study also showed from baseline 65.5 visual acuity. When we switched over, there was actually negativity, like it was the visual acuity was deteriorated. And in far retina study, when we switched from aflibercept or any other anti-VEGF injection, the visual acuity was only 0.3 gain, and treatment naive patients gave a 3 point, like it was good gain of 3.7 value. So this showed treatment naive patients can give a good result in faricimab injection studies. But if we switch over from other anti-VEGF alternative to faricimab, it will not give so good result, or something efficient. So it is not a very significant study. In this Kataoka et al. Study, we saw there were 130 eyes previously treated with aflibercept, which were switched over to faricimab for less than 4 injections, followed by minimum Q8 intervals. But we concluded that from baseline to 6 months, 60% of the patients discontinued faricimab. 92% of that, 92% of the patient discontinued due to insufficient efficacy, and 73% switched back to aflibercept. And in this study, we realized that there was no change in visual acuity, only minimal CRT change, and majority did not extend beyond Q8 interval. In Kishi et al. Study also, after 3 faricimab injections, there were no change in visual acuity. Mixed outcomes were seen, like central choroidal thickness did not change significantly, but central retinal thickness actually reduced significantly, and majority did not extend beyond Q8. So this study show that it may reduce the central retinal thickness or fluid, but it will not substantially reduce the injection burden if we use faricimab injections, or if we switch from aflibercept to faricimab injection, it will not reduce the burden of injection for patients. In Hara et al. Study, we compared aflibercept and faricimab injection on month 1, month 2, and month 3. In this graph, you can see blue bar is the aflibercept and gray bar is the faricimab injection visual acuity response. You can see after giving injection aflibercept, it gave such a good response in visual acuity, and it was definitely more than faricimab response. At second month also and at third month also, aflibercept response was more than faricimab injection visual acuity response. So there was significant improvement in visual acuity from baseline, which is p-value 0.0047 versus faricimab group. So mean central retinal thickness markedly improved from baseline to month 3 in both aflibercept and faricimab groups. Again, as it is showing, central retinal thickness was definitely improving in both the groups. But visual acuity gain was better in aflibercept group, and switching over does not substantially reduce the injection burden in all such patients and study. Even prior intravitreal treatment, 72.1% of previously treated eyes were switched from aflibercept. In this injection, in this graph also, you can see the same. In Belisi et al. Study, that 86% of patients are switched from aflibercept. Despite multiple faricimab injection, majority of patients are in less than Q8 interval. Several different approaches have been attempted in an effort to improve the patient outcome. Like if we can combine 2-3 injections or 2-3 compounds to give a better outcome to the patient. So these are the several different approaches which were attempted. Aflibercept 2 mg plus nesvacizumab, faricimab, brolucizumab, and ranibizumab ka surgical implant. Let's first learn about the additional pathway of aflibercept and nesvacizumab. In this, we can see in both wet AMD and DME, if we give aflibercept plus nesvacizumab, the combination provided no additional functional benefits. You can see there was a similar response with both, with this compound, with this mixed therapy in both wet AMD and DME. In faricimab's pathway, if we studied wet AMD and DME, it was a non-inferior efficacy, means the response was not very inferior with as compared to aflibercept across all the indications like wet AMD or DME, if we change the compound to faricimab. Faricimab failed to meet the primary endpoint of superiority to ranibizumab for BCVA gain at week 36. Levels of angiotensin 2 inhibition were similar between the agents, suggesting that the anti-angiotensin 2 molecular fragment of faricimab may provide no additional benefit over anti-VEGF monotherapy, as it is already been said that anti-angiotensin 2 can be helpful, but it is not giving any additional benefit over the anti-VEGF monotherapy. So aflibercept showed the most durable effect in blocking the effect of human VEGF on angiotensin 2 level in this preclinical rabbit model also, as it was shown in this study. The results of this study support the hypothesis that angiotensin 2 may be expressed secondary to primary insults to retinal vasculature by VEGF, and direct inhibition of angiotensin 2 may not be clinically relevant, as this is currently provided by anti-VEGF treatment alone. VEGF receptor pathway remains the master regulator in retinal disease, actually. So VEGF receptor pathway, you can see here in inflammation, neovascularization, and retinal vascular leakage and edema. Any pathological condition will increase the VEGF and placental growth factor levels due to hypoxia. So expressed by multiple cell types under pathological conditions, which will bind to VEGF receptor 1, and both VEGF A and PIGF are key components of inflammatory response cascade. Aflibercept is the only widely approved agent that blocks all VEGF R1 ligands. Other approved anti-VEGF agents like brolucizumab, faricimab, and ranibizumab, despite complete inhibition of VEGF-A, PIGF-mediated effects can still be activated through VEGF receptor 1 signaling. Aflibercept targets the VEGF, the master regulator of disease pathology, and additionally targets the key ligand of PIGF. So summarizing, with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Increasing the molar dose of an anti-VEGF agent may have the potential to offer patients more through extended VEGF suppression. Aflibercept 2 mg has set the bar high for treatment of any exudative retinal disease, with novel agents yet to surpass its standard of care vision gains, durability, and safety profile across indications. Aflibercept targets the key ligands of the VEGF pathway, the master regulator of pathological angiogenesis. Targeting other pathways has not resulted in improved patient outcomes beyond aflibercept, like angiotensin 2 or anything. Data from Pulsar or Photon suggests aflibercept 8 mg has potential for greater and longer lasting control of the underlying disease compared with aflibercept 2 mg through sustained disease control. Thank you so much for patient hearing.
Thank you, ma'am. Thank you so much for the wonderful presentation. And we will park the question for the at the end of meeting. And
Yeah, sure.
yes. So, and now I would like to invite Dr. Prakhar Shingai, who is basically from the Bhopal, and he is a very high skill ophthalmologist and veterinary specialist based at Bhopal, Madhya Pradesh. He has over 11 years of the experience in advanced eye care, specializing in the complex retinal surgeries, cataract removal, and the uveitis management. He has completed his prestigious retina fellowship from the renowned SN Chennai, and currently he serves patients at senior consultant at CFS Bhopal. And his topic is the wet AMD, critical information for the clinicians to enhance patient outcomes. So over to you, Dr. Prakhar Singhal.
Hello, good evening, everyone.
Good evening,
So
sir.
today, yeah, so thank you, Bhaivar and IDEA team for inviting me. Is my screen visible?
Yeah, it's coming, sir. It's visible. Uh,
One second. Okay, now it's visible, and am I audible?
yes, yes, sir.
Okay. So today we are going to talk about wet AMD, and so this is my disclaimer. So as we know, one second. So as we know, the age-related macular degeneration is present in the global world population. It is approximately 8.2 billion people, and it is going to be approximately 288 million by 2040. So that is a huge population which is going to be affected by this AMD. And in this, actually, what happens is there is sudden and rapid worsening of the visual impairment, including blurring of vision, central vision distortion of lines, letters, and it can lead to further central scotoma, and general haziness also is present. So if like this is a picture in the early ages when the patient see a black spots or something like distortion of line and letters. So it can be divided into the two stages. So AMD can be divided into stages, early AMD and late stages. So in early AMD, there will be accumulation of material drusen's underneath the retina, and it can be like early drusen's, and then it can be the increase in the changes with the drusen. So in the late stages, it can lead to either a juvenile EMD. So these are the pictures as you can see in the presentation. Picture and ICG, we can see distortion of lines. So is the vision lost? Early diagnosis, prompt referral, and shift to access to therapy are critical because untreated AMD can lead to permanent vision loss shortly after the onset of symptoms. So, early treatment can lead to a restoration of vision, and as the disease progresses, can lead to permanent blindness also. So, so let's talk about the mechanism of action. So, what is this pathogenesis? So, there is a vascular endothelial growth factor, which is VEGF-A and VEGF-B, and there is again a PIGF, that is pigment placental growth factor, which binds to VGRF1 and VGRF2, which leads to vascular leakage, edema, inflammation, and pathological neovascularization. So this in the picture we can see how they are acting, and there are multiple, as it has already been discussed, that there are multiple anti-VEGF which are available. So how the aflibercept is different from the others? So in aflibercept, it binds to both VEGF1 and VEGF-A and VEGF-B, and also PGIF1 and 2. So it is more potent than the other receptors, as they do not bind, they only bind to the VEGF-A. So the VEGF-B is still unbinded, and which can further lead to again the edema and inflammation. So these are the different molecules which are available. So why aflibercept? Because it has a stronger binding affinity than the other molecules, and also the half-life is approximately 9.1 to 11 days, which is further more than the other molecules. So why aflibercept is a choice? So now let's talk about the studies which has been done before. So now we are talking about the entire study. So in this study, it was a multi-centered randomized open label phase 4 study, and which was done in a treatment naive patient in the AMD. And in this, the patient received on the three loading dose, that is 0, 2, and 4. And after that, at the week 16, the patient were uh, divided into 1:1 ratio, and they were received at 2 weeks and 4 weeks of interval. So in this at the so it was taken at 50, so the main thing was, it was the mean change in the BCV at the baseline at 52 weeks, and at the end of the this at 96 weeks was seen. So the requirement, as we can see in this picture, at 52 weeks, uh, the 2 weeks of interval was the mean VA gain was 8.4, and at the 4 weeks it was 8.4, and the 2 weeks it was 9. So there was not much any significant difference between the 2 weeks and the 4 weeks. And at 96 weeks also, it was 7.6 and 6.1. So this was also not a significant difference was there in the both the groups. So the mean number of injection at 52 weeks was in 2 weeks group was 7.2, and at 4 weeks was 6.9, and at 96 weeks at 2 week group was 11.8, and at 4 weeks was 10.4. So this again, it has been like the study has been going on, and so there was a view, and which was done till the 212 weeks, and again at 52 weeks it was 10.4, and at 96 weeks it was 10.2 ETTRS letters. So the vision gain maintained for approximately 4 years, and which with continued proactive dosing as per the study protocol. Again, there are multiple studies. Again, this studies also shows that the mean number of injection for over 2 years was 13.6, and the vision gain at the 24 months was more than 6 letters. This is again another study which again shows about 1 year, 2 years, and 3 years the dosing of the injection, and again the results were similar in the as the previous study which has been discussed, and again the mean increase in the letters were 6.3. So these are again the figures which shows about the real world scenarios, and the aflibercept again stands in a very good position in CNVM. So now let's talk about PCV, how aflibercept acts in a PCV. So we have got a trial, that is a planet study. Yes. So first of all, the PCV is very common in the Asian population, and it is the most uh, like dangerous part, and it is about 22.3% to 61.6 in the Asian population, and it is also again second common in the Caucasian, and there are a lot of patients in the Caucasian population which are have not been diagnosed or undiagnosed, like missed. So now let's talk about the planet study. In the planet study, it is a prospective multicenter double mass time controlled randomized phase 4 study. And this study was between the comparison of monotherapy with aflibercept versus aflibercept with PDT. So again, there was a monthly 3 dose of injection was given, and after 8 weeks, the two groups were at 12 weeks. They have been divided into groups, and the one group which received aflibercept at every 4 weeks, and another group which receive aflibercept plus PDT. So in this, at the 52 weeks, so there was not any much difference between a single monotherapy of aflibercept versus the aceflibercept with active PDT. That is the there was a 10.8 and 10.7 mean gain in the vision. So that was not much difference. And again, the study was went in the 96 weeks, and there was again not much difference between the two groups. So the monotherapy, the mean gain in letter was 9.1, and the mean gain in letter with the PDT was 10.7. So in both the groups, there was about more than 80% of patients which shows no evidence of active polyp at 52 weeks and 90 at 96 weeks. So these are the again various studies which are being conducted, and again the monotherapy with aflibercept shows a good result and a comparison or a non-inferior result than with the combination of therapy. So these are the different type of which are available: brolucizumab, faricimab, and aflibercept. And the IUI and retinal vasculitis rate has been shown to be less in aflibercept, that is 0.006, and retinal vasculitis has been shown to be 0.002 in aflibercept compared with the other VGF like brolucizumab or faricimab. So there has been more than 20,000 patients in across 20, more than 20 countries which has been treated with aflibercept, and the rate of IOI is zero point 0.1 in 10,000 unit, and the rate of endophthalmitis is 0.6 in the 10,000 units, which is very, very less. So it is a very safe drug, and it is giving a immense and very good results to everyone. Thank you so much for your patiently listening. Hello.
Yes, thank you, sir. Thank you so much for your presentation. And now I would like to introduce Dr. Urmil Shah. So Sir, are you there?
हेलो
सर हाँ ओके मैं કહ્યું સર તમારું નામ ના દેખાય
हेलो
hello sir વોઇસ સર થોડોક ઇકો થાય છે
just a minute, is this proper now?
हाँ sir just give me a second sir है ना yes just give me a second yes so ladies and gentlemen it's my privilege to introduce Dr. Urmil Shah from Bharti Eye Clinic and he has the gold medalist from the Dr. Venkatesh Swamy Gold Medal in the ophthalmology during the training at the renowned Arvind Eye Hospital, Tamil Nadu. And he has the vast experience of the 1500 retinal surgeries covering from the entire spectrum from the vitrectomies for the retinal detachment and the scur buckling. So beyond his clinical and the surgical accomplishments, Dr. Shah is active contributor to the academic community and he has presented more than 40 papers, poster videos and lecture at the state, national and the international forums. So over to you, Dr. Urmil Shah, sir.
Thank you, Nurup and Bayer, and I thank my esteemed co-presenters for their presence. I will need a small technical help. How do I share my presentation?
Sir, have you logged in? Tech team, can you help me?
यस सर
How do I share my presentation?
फर्स्ट ऑफ ऑल आप बैकग्राउंड में अपना प्रेजेंटेशन ओपन कर दीजिए
It is open.
फिर वापस आप जूम में आ जाइए
Okay, just a minute. पहले okay.
फिर आपको
हाँ
फिर आपको नीचे शेयर का बटन दिख रहा होगा
ओके ओके
उस पर आप क्लिक कीजिए
हाँ
उसके बाद आपको एप्लीकेशन विंडोज में आपको अपना प्रेजेंटेशन दिख रहा होगा उस पर डबल क्लिक कीजिएगा
शेयर
यस सर Yes, sir. Perfectly visible.
Perfect. It's visible. Sir, your voice is not coming. Sir, can you unmute yourself?
Is this better now? I think the host had muted me. Something like that did happen.
Okay, it's fine. So now we can just share this.
Am I audible now?
Yes, sir. You are very much audible, sir.
Okay. So this disclaimer we have already gone through it. So the limitations of the clinical trial is that it basically does not represent the patients we see in routine practice. And also there is lack on consensus on the ideal treatment regime for DME, like should we use monthly injections, treat and extend, or PRN. So these are the trials, the landmark trials that we already had for the anti-VEGFs in DME, the Rise and Ride for ranibizumab, the Yoshimite trials, the Kite and Pestle for policizumab. They all have told us that if you give monthly injections at the end of 52 weeks or 104 weeks, we have improvement. But how many patients keep on coming back for monthly injection? That is the drawback with us in our clinical practice. Out of all of this, aflibercept already has been established as a gold standard through Protocol 3, Vivid and Vista, where patients with decreased baseline visual acuity benefit the maximum when you give them aflibercept right from the start. And this the increase in the visual acuity, the decrease in the or the stability in OCT is maintained right till at 3 years or 2 years. So real world data needs to complement the data from the RCT, and this is what we need to come to a consensus on. So the RWE provides essential information on the patient impact, the worldwide differences, the value of treatment. So there's an endurance trial where the patients from Vista maintained visual gains for 5 years, with an average of 3.4 injections in year 5. So that is what I tell all my patients, that diabetes is a chronic disease. It's not going to get better in just probably 3 injections. But if you keep on taking the injections as and when needed in the treat and extend regime, over a period of time, the number of injections will come down. So as you can see, there is a substantial reduction of the treatment burden through 2 years, where 25% of patients required no retreatment and 48% of patients required 5 or fewer injections. So aflibercept provides the real-world vision gains consistent to those seen in the RCTs, like the Apollon trial or the Moorfields trial. These were the two trials where 52% of treatment-naive patients received early intensive therapy with 5 monthly loading doses, and then they continued, and then the visual gain was maintained with fewer injections. The Draco study said that meaningful vision gains or maintenance with aflibercept is there regardless of the baseline vision if you keep on giving the injections as and when needed. The mean BCVA at month 12 in treatment-naive patients was 2.5, was addition of 2.5 letters. For those with baseline visual acuity less than 70 letters, the mean BCVA was in fact better, plus 7.3 letters. So as we said that patients with worse visual acuity have a lot more to gain when treated with um, initially monthly loading dose followed by the treat and extent of aflibercept, and 75% of patients maintained the diabetic severities, the severity level also at the month 12. This is just the repetition of what I actually said. Yeah. So there was a very nice study that said that versus dexamethasone for recalcitrant DME in pseudophakic eyes, and they compared patients where they had 3 monthly dex implants followed versus the monthly intravitreal aflibercept injections, and the patients had been previously treated with ranibizumab, and they concluded that both aflibercept and that provided similar visual and CMT improvements in recalcitrant DME, and the IVA leads to a more than 3 line vision gains but requires more injections and follow-up. So, aflibercept has established itself not only in treatment naive but also in recalcitrant diseases for treatment of the diabetic macular edema. This we already know that the anti-VEGF therapy is more effective in improving vision in recalcitrant DME than macular laser. So international recommendations and guidelines is the first line of use of aflibercept patients with visual acuity less than 20/40, and this is pretty much a commonplace in scenario when patients don't present early, patients present late, and there the instead of giving ranibizumab, probably aflibercept as the first line would give more benefit to the patients. So a Cochrane meta-analysis reviewed the evidence from major studies investigating the efficacy of anti-VEGF agents in DME, and they found that at year 1, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab, and patients were 30% more likely to gain more than 3 lines with aflibercept than with the other two molecules. Aflibercept is the most favorable treatment for patients with DME that we already know, that is the gold standard. So it basically has a treatment-free interval of about 8 to 10 weeks in DME. The treatment-free interval in wet ARMD is bit more, about 12 to 14 weeks, but I find 8 to 10 weeks is the treatment-free interval I get in aflibercept patients for DME. This is just a repetition of what we already discussed, that 2040 of was the guidelines will be aflibercept as the drug of choice for DME, and patients if they patients with worse vision, aflibercept may result in a more rapid visual improvement. Superiority is noted in the groups with worse baseline visual acuity. and evidence of possible difference in drug efficacy in patients with DME to the disadvantage of bevacizumab is seen. So aflibercept is recognized as a standard of care in DME and is used in a 4 DRCR retina network protocols evaluating anti-VEGFs in DME and DR. So I'll just present a case where a 52-year-old male diabetic with NPDR with CSME has previous 3 doses of Xentrix. The last dose was given 2 months before presentation at our place. Severe NPDR was noted in both the eyes. Uh, so patient has this OCT, and after 2 injections of aflibercept in both the eyes, the right eye vision is 6/9, the left eye is 6/12. There's quite a dramatic improvement in the edema resolution. The right eye has a bit of edema, so we give another 3 injections of aflibercept. This is the time where the Bayer program for patients was going on, so the patient had the benefit of 5 injections in each eyes under that program. And after 5 injections in each eye, the right eye is quite stable. The left eye is having a hard exudate plaque. So now the decision was taken to give an injection of Ozurdex for the hard exudate plaque in the left eye and oral fenofibrate to the patient. So this is a article I found quite interesting for intravitreal aflibercept on reclassification DME. And this one, that in vitrectomized eye, they found the efficacy of aflibercept was superior to that of ranibizumab, bevacizumab, and as well as brolucizumab. Thank you.
Thank you, sir, for the wonderful presentation. If any questions from the audience or the doctors? There is one coming as sir. How was your experience with the FLE?
Okay, so could the question be elaborated more? In what disease pathology are they asking? In every aspect. Okay. So obviously, aflibercept has a more, in my experience, a more better response in wet AMD than DME. But I find the response of aflibercept to be quite gratifying in vein occlusions. Like if I had a patient of vein occlusions, I've given 3 ranibizumabs, and if I have to switch, I find it to be more better than brolucizumab for vein occlusions. Obviously, it's good for wet AMD. For DME, I find that the number of injections are quite high to get the same response. So probably for a DME, I'm more partial to a brolucizumab if I want to reduce the number of injections. Probably the other speakers can have their experience in this.
So, Dr. Harsha ma'am or Dr. Prakhar sir, would you like?
Definitely, aflibercept gives a better result in wet AMD patients. And DME, it is almost equal to other anti-VEGF response and aflibercept. It is almost same, but better response is in wet AMD refractory to any other treatment with anti-VEGF. Aflibercept will give a very good result, and it will be extended treatment regimen also. We can give after 2 months also. The response remains the same. That injection treatment burden also reduces with aflibercept in wet AMD patients. But it is not so, like it is similar with other anti-VEGF if we are treating a DME patient or as retinal vein occlusion patients. I have not observed so much difference with aflibercept or any other alternative and injection. But Dr. Urmil is saying so, it must be correct.
Thank you, ma'am. Thank you, sir. So I think if there is no other questions, then we are good to close. So thank you very much, all the speakers and the audience to join. Thank you, sir. Have a good
Thank
night.
you for setting this up. Thank you very much, dear.
Thank
Good
you.
night.
Thank you. So, tech team, we can close the session.